Welcome to Chatnite, we bring you good vibe, we shine on the light. Welcome to Chatnite, we bring you good vibe, we shine on the light. We all over the world, Chatnite Africa. We all over the world, Chatnite Africa. Welcome to Chatnite, we bring you good vibe, we shine on the light. Welcome to Chatnite, we bring you good vibe, we shine on the light. We all over the world, Chatnite Africa. Chatnite Africa. We all over the world, Chatnite Africa. Chatnite Africa. Welcome to Chatnite, the only place that we give you good vibes. Chatnite Africa. Welcome to Chatnite, all over the world we are shining the light. Chatnite Africa. Welcome to Chatnite.
Hello, everyone. Welcome to this week's edition of Healthline on Chatnite Africa. My name is Divine Chamukong, and I'm anchoring this broadcast from Washington, D.C. metropolitan area. Have you ever thought of doing a colonoscopy? You ask, what is it, Divine? It is colon cancer screening. You ask again, what's the big deal about it? 150,000 people are diagnosed every year with colon cancer. 53,000 people die of it annually. Don't forget this. Colon cancer does not know geographical boundaries. As a matter of fact, as we speak, someone is developing colorectal cancer. That's why you will find this broadcast extremely important. Ladies and gentlemen, to take my questions, but also yours, because we will be opening the phone lines to the public, is one of the best and brightest in the United States, gastroenterologist, Dr. Ivo Dita. Dr. Ivo Dita, thank you for accepting to take questions yet another time on Chatnite Africa, this time on Healthline.
Divine, thank you so much for inviting me once more to this platform. It is always an honor for me to come on Chatnite Africa and discuss matters of prime importance to our people and to the general population. In fact, I will not pass on any of such opportunity to come on and try to explain, help our people understand why it is very important for them to do what we're going to be talking about today. As you highlighted in your opening remarks, tonight's topic will focus on colon cancer screening. And it is a huge problem. Colon cancer is a big problem. As we will delve into the details, I will let your audience understand the significance of this problem and why it is important that they should go and get screened for colon cancer. So once more, thank you so much for inviting me on Chatnite Africa tonight.
Dr. Ivo Dita, you are a gastroenterologist. What do you do on human beings when they come to see you?
Yeah, just like, a gastroenterology is a subspecialty under internal medicine. So to become a gastroenterologist, we first complete a residency training in internal medicine. And after that, we go on to do another 3 years of training to become a gastroenterology subspecialist. So my day-to-day work entails taking care of patients with multitude of gastrointestinal problems. And by those, we are referring to anything that starts from the esophagus to the anus, including some of the organs that participate in digestion, including the pancreas and the liver. So my day-to-day work actually focuses on this system and you're looking at things such as any patient with abdominal pain, nausea, vomiting, trouble with swallowing, diarrhea, bloody stools, becoming yellow because they got jaundice, or who are simply losing weight because they cannot absorb food. And of course, the topic we will delve in tonight will focus on colon cancer, which usually develops from abnormal growths in the colon, which, if left in place, can grow into a colon cancer. And we got a good opportunity to track down these polyps or these precancerous lesions at a stage where they haven't yet developed into cancer, and we can do something about it before it develops into cancer. So I look forward to that discussion tonight.
We love Chatnite Africa.
Dr. Ivo Dieter, what exposes the human body to colon cancer?
To start with, I would first of all just like to make a brief introduction here so that our guests, our audience can understand why it is very important that they pay attention to colorectal cancer as a whole. It is very important to know that in the United States, where we are based, about 150,000 individuals develop colorectal cancer each year. And by colorectal cancer, as the word rightly seems to suggest, we are referring to colon and the rectum. These are parts of the digestive system. So about 150 individuals, 50,000 individuals annually develop colorectal cancer. And among this number, about 53,000 die each year. Again, 53,000 individuals dying from a problem that we have the tools to prevent. So that is how big the issue we are talking about tonight is. And you ask a very important question about what predisposes somebody to colorectal cancer. And on that topic, we will talk about potential risk factors. It is important for the audience to understand that colorectal cancer, the risk factors of colorectal cancer are either environmental or simply things that unfortunately you were born with that you do not have any control over. But by virtue of simply getting older, meaning as we get older, that is the strongest risk factor for developing colorectal cancer. It is the reason why the guidelines all over the world recommend that each and every one of us that gets to the age of 45 needs to go in and get screened for colorectal cancer. There are other factors that can determine whether you need to go in earlier than the age of 45 or not. Those are the genetic factors that we're talking about. Some people are born with some genetic defects that put them at a higher risk of colorectal cancer. And those people may develop polyps at a very early age. We're talking of ages as low as 13 years old. Those are people that belong to families that are known to have cancer at a very early age. And most of these people have been genetically tested. If you find yourself, especially in a developed country, and they've been found to have genetic defects that predispose them to colorectal cancer. It is important to also know that colorectal cancer is the third most common cancer in men. And it is the second most commonly diagnosed cancer in women. Overall, men also seem to have a higher risk for colorectal cancer compared to women in general. And as I pointed out, the good news about development of colorectal cancer is that there does exist a precancerous lesion that usually takes averagely about 10 years to develop into colon cancer. So during this pathway, these course that last about 10 years, if you happen to get screened, we can detect these lesions, which are known as polyps, remove them so that they do not develop into colorectal cancer. And by the way, even if you happen to develop cancer, I think each and every one of us would prefer to be diagnosed at an early stage where the cancer can still be treated. Because if you wait for symptoms to occur before you go to see your doctor, most often than not, that is at the point where there is very little that can be offered in terms of cure when it comes to colon cancer. So it is very, very important that we understand that screening is done on people who do not have signs and symptoms of a disease. That's the difference. Screening is done in people who do not show any signs or symptoms of a disease. So if you sit and you are waiting and telling and excited, going about enjoying yourself, saying that, why should I go get a test when I do not have any symptom? Unfortunately, when polyps are developing, you are typically asymptomatic, meaning you do not have any signs or any symptoms. And by the time signs exist, it might be too late.
Keep watching Chatnite Africa.
Ladies and gentlemen, before we came on the platform, Dr. Dieter did a video so that when we talk about colon cancer, you know exactly where in the body this is all about. Here is Dr. Ivo Dieter.
So we're right now in the GI clinic, somewhere in Twin Cities, St. Paul. You can see some of my wonderful nurses that do a brilliant job right here in the clinic, and we are very grateful for having them. As we walk around here, you'll find a lot of tracts that we give out to our patients as information to help them understand their disease pathologies. These are several rooms where we receive patients. But today we will be talking primarily about colorectal cancer screening. And as you're well aware, the month of March is the colorectal cancer month. And I just wanted to do an overview of the digestive system so that as we continue with our discussion today, you will understand the various parts of the GI system, why we do colorectal cancer screening, and why it's important to do it on time. So right here, you have the digestive system. This is the upper digestive system, the esophagus, the stomach, the small intestine, and this is the colon. When we do colonoscopies, we primarily examine the colon. Colorectal cancer is a very common cancer. It affects millions of Americans yearly. The good news is that it often takes a very long time to develop colorectal cancer. And the initial process in the development of colorectal cancer starts with the development of a polyp. And a polyp is a small growth that, if left in place, it will grow into a cancer. And as you can see, this tiny polyp, which would take about 10 years to develop into what will become a cancer. And this is exactly what we do not want to happen. So from when the polyp starts until when it becomes a cancer usually takes averagely 10 years. So if we are able to catch anyone at the stage before they develop cancer, we are able to remove that polyp. So the goal of colorectal cancer screening is to remove these lesions at the stage where they are not yet cancers. And that's very important, because once they become cancers, it becomes very difficult to manage. And sometimes it is at the stage where very little can be done, and those patients end up dying. This picture also shows you other risk factors of colorectal cancer, including chronic inflammatory bowel disease, with the most common being ulcerative colitis. And this, because of the chronic inflammation and irritation to the colon, there is a high chance that that area of the colon can develop cancer. So also very important. These and other risk factors we will be discussing in the course of our discussion tonight. And I'm hopeful that at the end of the day, if you have any questions, please do not hesitate to ask us. So again, colonoscopy primarily focusing on the colon, and the goal is to catch these precancerous lesions at a stage where they are not yet cancers, so we can remove them to prevent you from developing colorectal cancer. Thank you very much, and I look forward to the rest of the discussion.
Thank you, Dr. Ivo Dita. And I told you, when we come on this show or this platform, we bring you the best and the brightest. Once again, ladies and gentlemen, join me now in welcoming Dr. Ivo Dita, gastroenterologist, on the platform. Dr. Dita, growing old is attributable to wisdom. But here you are telling us when you grow old, you're exposing yourself to colorectal cancer. Why is that so?
A good question, Divine. You know, it's a question I hear quite frequently from my patients. And one of the responses, jokingly, that I give them is that, unfortunately, we do not know why. And they laugh at me, but that's the truth. We know risk factors, but we cannot explain why these things happen. But if you look at it in general in the population, you will see that as people get older, they are often more likely to develop cancers or tumors. And the general theory is that as the cells in the body multiply over and over, divide over and over, there is a higher chance that as the division keeps going on, there is a chance that one of the cells can become abnormal. And it is that abnormal cell that is no longer in check by the body systems that will grow to become a tumor. And depending on what kind of cell that is, you may develop a cancer. If that is in the colon, that will happen. When we looked at that figure, first, I want to correct that. I said millions of Americans develop cancer. No, that's not true. 153,000 people annually are diagnosed with colorectal cancer. That was really an over exaggeration. But on that figure, one thing that catches our attention is what I also mentioned about inflammation. And one of the conditions I mentioned was ulcerative colitis, which is a type of inflammatory bowel disease. So each time you have chronic inflammation that irritates a structure, that can make the cells in that area, as they try to fight the inflammation, to divide and multiply, to develop an abnormality, to develop a genetic defect, to develop what is commonly called a mutation. And once cells develop mutations, a lot of times the body systems are able to take care of those cells, but sometimes they get out of control. And check mechanisms that your body has will no longer be able to control this out of control cell, and it will have a tendency to develop and grow into a tumor such as colon cancer. So that is why age is well established, is the single well-known factor that determines on which guidelines for colorectal cancer are based. If you are an average risk individual, you do not have, for example, the chronic inflammatory condition that I mentioned. You do not have any of the genetic defects that I mentioned. I don't want to get into them because that would be too detailed. At the age of 45, you need to be going in to have screening for colorectal cancer. I also want to point out that other individuals that come from families where they've developed colon cancer earlier than the age of 60, those individuals typically do not wait for the age of 45. They're actually advised to start colorectal cancer screening at the age of 40. So it is important to know the history of your family. And when we talk of your family, primarily your first degree relatives. And by first degree, I'm talking about your mom, your dad, your brother, your sister, or your child. If any of these individuals develop colon or rectal cancer earlier, young, when they are still not up to the age of 60, that really puts you at an increased risk. You will not be waiting for the age of 45 to go for screening. You will actually go for screening at the age of 40. And let's assume that your brother developed colon cancer at the age of 35. In that scenario, you're not going to sit waiting for the age of 40. You're actually going to start colorectal cancer screening 10 years younger, earlier than the age when your first degree relative was diagnosed. We use another example. My brother gets diagnosed at 35. I have to start screening at 25. My brother gets diagnosed at the age of 55. 55 minus 10 is 45. No, I start at the age of 40. So if the age at which your first degree relative developed colorectal cancer, you subtract 10 from that age. If it is earlier than 40 years, you have to start at that age. If it is above the age of 40, you must start at the age of 40. But the genetic conditions we talked about, like the most common is what we call the familial adenomatous polyposis syndrome, or FAP. And there's also something called Lynch syndrome. People that come from these families actually start colorectal cancer screening at the age of about 15. And people with FAP, or familial adenomatous polyposis, your lifetime probability that you will develop cancer is 100%. It is just a matter of time. It is not whether will I develop. No, it is when it is going to happen. That's why we keep a very close eye on these people. They get colon cancer colonoscopies every 1 to 2 years. And once we find these polyps, we typically recommend removing the entire colon, because the polyps are so many that you cannot even attempt to take them out on colonoscopy. So the typical recommendation is they get their colon removed. So that is so nobody knows exactly why polyps develop, but if you understand some of the examples I just used, the repeated division of cells, the chance that one can get out of control, chronic inflammation, genetic risk factors, then, and coming from a family where colon cancer is diagnosed at an early age, or polyps are frequent in that family. And it's not every type of polyp. Again, we don't want to go into too much detail, here, but we do have certain types of polyps which can make us determine that you need to start colon cancer screening, or your family members need to start colorectal cancer screening at an early age. We call those advanced polyps, and they include if your brother or sister has had a polyp bigger than 1 centimeter, if they've had a polyp that is described when they examine it under the microscope as saying it has high-grade dysplasia. Dysplasia are the changes that progress to cancer. If they say your family member has had a polyp with high-grade dysplasia, you will also be treated almost like somebody that has colon cancer, or that comes from a family with early onset colon cancer. And the last option is something we call it's a villous polyp. That again is based on the tissue being examined under the microscope. And it is important for our audience to also understand that if you have had 10 or more polyps cumulatively, it doesn't matter whether it is on one single session of colonoscopy or 3, you have to be referred to a genetic counselor to get screened for a genetic defect that may be running in your family and putting you and the rest of your family at higher risk of colon cancer. In that situation, you may be found to have one of those conditions I mentioned, and your children may need to start screening at the age of about 15, not waiting for the age of 40.
We love Chatnite Africa.
And today, we have one of the very brilliant medical doctors we have here in the United States of African descent, gastroenterologist, Dr. Ivo Dieter. Dr. Dieter, when you talked about environmental factors that could predispose people to colon cancer, it got my attention. Would you please illuminate on that? Is it what we do, where we live, the kind of houses we live in, or the kind of cars we drive in that expose us to colorectal cancer?
Yes, I think that's a very important question, Divine, because a lot of the things that we've spoken about can be categorized as non-modifiable factors, meaning, unfortunately, you can't do anything about. For example, you cannot say, I wouldn't get to the age of 45. You can't say, I wouldn't get to the age of 50. You will. You can, if you were born with a genetic defect, unfortunately, you can't do anything about it. You have the defect. So those are the non-modifiable risk factors for colorectal cancer. However, there are certain lifestyle factors that have been identified that could potentially increase your risk of colorectal cancer, but there are also some that could protect you. Simply put, we know that a diet that is high in fat, high in red meat or processed red meat, there have been studies have found that there is an association between that kind of diet and an increased risk for colorectal cancer. So something to remember, a high fiber diet, a diet that is very rich in red meat or processed meat, has been found as potentially increasing your risk of colorectal cancer. On the contrary, a high fiber diet seems to be protective against colorectal cancer. So just on the side of modifiable risk factors, if you pay attention to your diet, you may actually improve your risk of getting colon cancer, or you may actually be increasing your risk. So important to pay attention to that. Other factors that have also been associated with increased risk include lack of physical activity. So even though we all know that physical activity is a very healthy habit to adopt. People think it's only to lose weight, but we in digestive care do know that sedentary lifestyle or lack of physical activity may actually increase your risk of colorectal cancer. I keep saying may because these factors have not been conclusively shown to increase the risk, but there is an association that has been found in studies that have been completed to indicate that they may actually increase your risk. Other modifiable risk factors include smoking, excessive alcohol use, and people who are obese. By obesity, we're referring to people who are overweight, who have a BMI which is greater than 25. And the bigger you are, the higher risk or association we see. So these are things that we can change, that we can do something about, and in so doing, may actually modify our chances, improve, or if we do nothing about this, increase the risk of colorectal cancer. There are other factors which have also been identified, like high vitamin D intake may be protective, but these are very controversial. Those that I just mentioned in the modifiable risk factor category are those that we do believe that there is a higher probability that they may impact or influence the risk of developing colon cancer. We do also know, Divine, that colon cancer incidence or prevalence varies in different parts, across different parts of the world. For example, the highest burden or incidence of colon cancer is actually in Australia and New Zealand compared to other Western nations. We also know that colon cancer is, the incidence or burden of colon cancer is actually low in developing countries. Now, we do not know whether the low burden noted in this country is primarily because they do not screen for colon cancer. There are several factors that we can advance to justify whether is it really that their environment, what the kind of exposures they have in terms of their eating habits, what kind of chemicals, smoking habits may actually protect them from developing colon cancer. We don't know because in these areas, unfortunately, for example, where I come from, colon cancer screening is not a routine practice. People probably get a colonoscopy only when perhaps they develop symptoms, and which we can delve into to talk about what potential.
We will come to that.
People may develop if they don't get screening and the polyp grows into a cancer. We will never know whether colon cancer is a big problem in those countries or not, because they generally do not have public health programs which are tailored towards screening for colorectal cancer.
If I ask the people watching now and those to watch later if they think they have colorectal cancer, the answer will be no, they don't. And the reason is they're not noticing any symptoms. So let's get to symptoms. What symptoms should one notice and begin to worry about colorectal cancer?
Yes, important to talk about those, but I want to stress that my goal here today is first to let the audience know that they do not have to wait for the symptoms that I'm going to talk about before they go to see their physician or to get screened for colon cancer. Most often than not, by the time you come with symptoms, it is too late. By that, I mean we may not be able to save you from dying. You do not want to wait. So, what are the most common signs and symptoms of colon cancer? Define the first thing is that there is no sign, there is nothing. You have it, you don't have anything until the day that something happens. And when something happens, what will that be? When we look at the figure I showed in the digestive care clinic where I work, we saw a very small polyp. When the polyp is at that stage, you can imagine stool moves very freely. The polyp is not blocking the lumen of the colon, so poop can move through very freely. As that polyp increases in size, one of the things it can do is that it can obstruct the lumen of the colon. If it gets bigger and bigger, it may get to a point where it completely blocks the passage of stool. And what will happen? That patient will present with a bowel obstruction. That's one thing to remember. Sometimes the tumor, once it becomes a tumor, it grows into the wall of the colon. And that growth can lead to a hole or a perforation in the colon. That patient will present to the hospital with a bowel perforation. That's another way colon cancer can present. Most often than not, patients go in to see their primary care physician. They get a blood test and they are told that their hemoglobin is low. One of the most common places where people lose blood is in their GI system. And once you have low hemoglobin, low iron, one of the things we worry about is whether your GI system or your digestive system is not in good health. And one of the things we will often do is perform a colonoscopy. So anemia, bowel perforation, bowel obstruction, sometimes it's belly pain as the tumor grows into the wall of the colon, starts eroding into the nerves, you will have abdominal pain. As that polyp is growing in size, the narrower the lumen through which stool has to go, you may show up to your doctor with the complaints that I am constipated, or my stool has become so narrow, what patients typically describe as pencil stools. Your stool is, which used to look something as a sausage, becomes something like a pen or a pencil. And at that point, some people are already constipated, but they present and say, doctor, my stool caliber has changed, and I'm not having very narrow or pencil-like stools. That would be another thing. Tumors can bleed. So patients, that's actually the reason why you develop the anemia. So you can also present to your doctor that I am seeing blood in my stool. Unfortunately, some individuals, we actually discover that they have cancer when it has already spread to another organ. And the most common organ where colon cancer goes to is the liver. So you may become yellow, you may be having a pain in the right upper quadrant where the liver is, and your doctor does an ultrasound and finds out that, oh, there are some small lesions all over your liver, and those are known as metastasis. It means the tumor has left the place where it was found, and it has gone through the bloodstream and has moved to a different organ, and which is what we don't want. Because once that happens, even if they took out the tumor, unfortunately, where the tumor has gone to, we might not be able to get that tumor out. So Those are the most common ways. Sometimes patients show up with weight loss. I'm eating, I can't gain weight. A lot of times too, they lose their appetite. These things typically happen in more advanced disease. If the disease is more and more at a more advanced stage, the patients are more likely to come in with night fevers, weight loss. I've lost my appetite. I'm very tired, typically because they may be anemic, but the tumor itself needs, the metabolism of the tumor is very high, so it needs a lot of energy to build itself up so it can get energy from the body. And these patients are typically very tired. So those would be the most common symptoms of patients that have colon cancer.
Keep watching Chatnite Africa.
Dr. Dieter, when you start noticing the symptoms, at what stage is the cancer? And I know that cancer is in stages 1, 2, 3, and 4. At what stage does it get to before you start noticing symptoms? And what can be done when it's at the stage we're about to talk about?
There is nothing specific. There is no sign or symptom that will be specific to a particular stage of the cancer. All the signs and symptoms I described can occur at any stage of the cancer. Of course, if your cancer has moved to another organ, what you are calling stage 4, meaning you have metastatic disease, you may now show symptoms of the new organ where the tumor has gone to. But in general terms, once you develop colon cancer, the signs and symptoms, there is none that is specific to the stage of the disease that you have. Any of those signs can occur in any stage. And the presence of the cancer outside of the colon, this may be the lymph nodes, this may be to other organs, only help us classify your disease into a different stage. But the signs and symptoms do not differ or are not dictated by the stage of the disease. On the contrary, for polyps, you don't have any symptoms. Go get screened. That's why screening is out there for you. It's like every woman who gets to a certain age is expected to have a mammogram. Whether your breast, you're feeling a lot or you're feeling nothing, go get screened. It is the same story for colon cancer. Do not wait for symptoms, otherwise it might be too late.
This broadcast is on 5 different platforms concurrently. You can watch it on YouTube in high definition. You can also watch it on www.chatniteafrica.net. That's on the internet, where we have a lot of people watching. I've just been told that by my social media platforms manager and tech support chief, Mr. Roger in Lagos, Nigeria, now, who is making sure this happens. You've heard all the troubles that colorectal cancer can take you through. Why would you want to go through this when you could have prevented that by doing a colonoscopy? We will bring back Dr. Ivo Dieter momentarily. I want to discover something which came out from a studio in Maryland only yesterday. You will love this. He's called Pabali, and you can find him on YouTube. Just search Pabali. You will love this song. I'll be right back.
Want to something for gonna begin? Make sure say that the way they talk so, not true you they talk, because if you change, I'm making it live. Miziki, not dame for the soul. People, them say music in a yeah them. I be grow for Bamenda. Papa show me the music. Country people, them say music in a yeah them. You know my own Bamenda didn't have my blood. They can say many musicians not get married. They can say many musicians not quarrel them all. They can say many musicians not get be house. They can say many musicians not get money. Them be the say any musician will get money, not young go money. Every year say they talk so I can't fear. Every year say they talk so I can't fear. All they talk put fear for my heart. I not be imagine say. They will discourage me from Ojobo. With the toxin from ESA. They say no me go pay. They say no boogie pay. I go le was all day, yeah. They say come and go pay. They say no boogie pay. I go le was all day, yeah. Let's talk to Famiba. Quadratic equation. Zero to India. Differential equation, reproduction in algae, coffee farming for Brazil, electromagnetism, life cycle for gamma lizard, static electricity, carica papaya, blah 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 blah.
Now you're the one that say, maybe, just maybe, if I was standing at Mutombo since that time, I could have been a different level musician today. And just maybe, yeah. So if you're picking to sing, Papa, I want to be a farmer. Maybe I want to be a bricklayer. Or I want to be a carpenter. Or I will not end up. What he put in.
If you name me for cross, normally never talk say lewa no fine. All the talk na say, if you go lewa for go study electron, neutron, proton, Einstein mass energy equation, then you don't get any business with coffee farming in Brazil and vice versa. Probably don't talk grammar, vice versa. But don't go enter your body, then you holler, oh yeah, yeah.
Right, that's Pabali. You can find Pabali on YouTube. Please like, share, and there's one of our on Chatnite Africa. You're watching Healthline. My name is Divine Chamukong, and I'm anchoring this broadcast from Washington, D.C. metropolitan area. On our platform, we have 3 programs running. We have Healthline, which is what we're watching now. We have Family Matters, and we have Voices of Africa. We have next Friday some extraordinary teenagers. Boy, you could think that they're senators. They are so eloquent, so knowledgeable, you'll be blown away by what you watch on Chatnite Africa next week. And remember, you can watch this show in high resolution, if you like, on www.chatniteafrica.net. It's a beautiful broadcast website. I mean, you'll be swept off your feet once you get on that website. You can also watch on YouTube. These are the areas where you can watch our shows in high definition. We're on LinkedIn. We're in 2 places on Facebook. So we are all over the internet, hitting the nooks and crannies of the planet each time we hit the airwaves. Ladies and gentlemen, once more, Dr. Ivo Dieter. Dr. Dieter, everybody asked me to take this question to you. Why do the symptoms of colorectal cancer go undetected for such a long time? Why do they hide so much?
Now, Divine, I don't know whether the symptoms hide. What we have,
they don't manifest.
Yeah, the stage where they do not manifest, typically it's the early stages of the disease. And our goal is usually to catch the disease at that stage. And by early stages, I'm referring to, remember when we talked about polyps, I said polyps usually do not cause symptoms. And when that polyp changes into an early cancer, typically the cancer too starts, it's small. We have what we call cancer in situ, meaning it's just inside the polyp. Sometimes it's not even grown into the wall like stage 1. Those may also not show any symptoms. But it doesn't mean that cannot show symptoms. It can have the bleeding, it can cause a perforation, it can cause anemia, pain, fever, night sweats, weight loss, changes in appetite. So I don't want our audience to live from here thinking that cancer does not show itself. No, when the polyp has gone into a cancer, you will have symptoms. Of course, if the cancer is early, it is also probably more likely that the symptoms you may have at that point are very subtle. They are not as prominent like what I described, but you may have the anemia. Your doctor may do your blood test and find out, because tumors in the colon typically bleed in very small amounts. And when that bleeding happens chronically, those patients lose enough iron, so much so that when the doctor does your blood count, he will identify that you have an anemia. But as that tumor becomes more and more advanced, the symptoms we describe are more likely to happen. So let people not walk away from here waiting to say, I want to see something before I go. The take-home message is, at the stage when we can do anything, whether it is when you have the polyp or it is early cancer detection, you might not have any symptoms. By the time you are having symptoms, it's too late. So go get your test done. That is the one single important thing you can do.
Dr. Dieter, another question, by the way, if you want to ask the doctor a question, the number is this: 240-603-7367. 240-603-7367. This guy is expensive to consult. We are bringing him here on Chatnite Africa. Pick up your phone now, ask him a question. Please don't meet Divine and say, I heard this question, because then we're talking in the past tense. Let's talk in the present tense now. Pick up your phone, 240-603-7367. 240-603-7367, and you will be heard throughout the planet. The question you have for the gastroenterologist, Dr. Ivo Dieter. Dr. Dieter, a lot of people ask me also to ask you, take this question to you. Why does colon cancer start where it is and then have to migrate like a tourist throughout the body? Why is that so?
Yeah, and we must understand that this is not unique to colon cancer. You remember that in our bodies, we have blood vessels that supply the tissues. We have veins, we have arteries that bring blood, we have veins that take blood away. And that blood carries the wastes that come from the tissues. When they have broken down food, made their energy out of it, the waste has to be returned somehow to get rid of. So when you have a cancer that is advancing and erodes into one of these vessels, wherever that vessel is traveling to, that cancer cell may be transported to that organ. And some cancers have affinity, or they like certain organs more than others, and they are more likely to settle in those organs than others. So the first place, so as a cancer grows, gets bigger, penetrates the wall of the colon, it begins to erode into the vessels that supply that colon. And there is also a drainage system, which we describe as the lymphatic system, that also drains lymph in the body. And that's typically the first place where those cells will go to. It is the first traffic or checkpoint when when drainage leaves tissues and waste is being transported away from that tissue. So far as that a cell breaks from that tumor into the blood vessel that has been eroded due to the tumor invading or growing into the tissue, that cell is carried to another organ. And once it settles in that organ, it starts the same process of multiplying in that new organ, growing bigger, and sooner or later you will have symptoms in that organ due to that cell that came there. So that's why we are saying that by the time the tumor goes to another organ, it is an advanced tumor. It is a tumor that has grown and gone to a stage that typically we don't often have much to do. You are coming late. And that's why the tumor has had all the time to grow into the wall of the colon, invade the vessels that supply and drain the colon, and then a cell breaks away from that tumor, is transported through that blood vessel to the next organ and settles there and grows like a metastasis. So it is a result of having waited for too long, and the tumor has grown out of control, invaded your cells, your blood vessels, your transport system that carried dirt away, and the system carried the cell thinking that it is some dirt, and that dirt settled in another organ and continues the process from where it came from by multiplying into a new tumor.
Keep watching Chatnite Africa.
Dr. Ivo Dieter, you say at some point there's little that you doctors can do. There's not much. What's the little you can do? And what is it? What really is it?
Yeah, so there's quite a lot, and it's a field that is changing every single day. First, we want to remove the polyp before it grows into a cancer. Today, I did about 11 colonoscopies, and two of my patients one of the patients had one of the largest polyps I've seen in my 12-year career today. And I bet you, if that patient did not come in the next 2-3 years, I have no doubt they would have developed cancer. But the stage at which I caught that polyp, despite the fact that it was a carpet-like huge polyp that took almost the whole wall of the colon, I can guarantee you that that woman is not going to develop cancer from that polyp. And that's what we want to do. Now, if she didn't come and came later on, 2-3 years down the road, maybe the polyp has transformed into a baby cancer. I would describe it that way, meaning it is still only inside the wall of the colon. If that is the case, meaning it hasn't gone to another organ, it hasn't invaded the nearby tissues, so it hasn't spread to any other place, we can simply go in, chop out that part of the colon, and you are free. You will not need chemotherapy. You will not need radiation therapy. We will not need to go to a different organ to try and take out the cell that came from that cancer. Now, if she didn't come after 2-3 years and came, let's say, in 5-6 years, and that cancer, which was a baby cancer, has now grown and invaded the next organ close to the colon, or it has grown and invaded the blood vessel, and the blood vessel have carried the tumor to another organ, at that point, even if we took out your colon, yes, we have removed the primary tumor, but where it has invaded to, we may not be able to remove it. And more importantly, the other organ where it traveled in the blood to go to, we might not be able to do anything. There are some special situations where we might be able to take out the tumor and do something to that lesion that has gone to another organ, but most often than not, when you have many, there is very little we can do. So depending on the stage where you are, that's why when we find out that you have cancer, the next thing we do is do a CT scan of your chest, your abdomen, your pelvis, to check and see if the cancer has gone anywhere else. And if we find out that it hasn't, we then say, let's quickly do surgery and take out the tumor before it invades the other organs. I must also warn the audience that unfortunately, sometimes the tests that we have today might not be able to identify the small cells that may have gone to another organ. That's why sometimes the doctor says, oh, your tumor is only in the colon. They take it out. But a few years down the road, you hear that, oh, they found a tumor in another organ, and they said it came from the tumor that you had in your colon. And you are asking yourself, but I was told that this was only in the colon. How come today, 3 years after, they're now saying that the tumor had gone to my liver? So there is a concept known as micrometastasis. What does that mean? It means that you have tumor cells that have gone to another organ, but they are so small that the current technology that we have in doing tests cannot identify. And that's why down the road, that small lesion, which could not be identified at that time, grows, and suddenly you are told that, oops, we now found that that tumor had spread to another organ. Again, the probability of that happening is a result of leaving the tumor in place for too long. If it is caught early, you can be cured. If it is caught late, we might simply just say a prayer and wish you good luck.
Dr. Jeter.
We love Chatnite Africa.
This is heartbreaking. Honestly, I don't know how you as doctors tell somebody that they are at a stage that all they can do is give them palliative care. It's heartbreaking. It's tough. It's tough. Now, you did 11 colonoscopies today. There was a case in Maryland where a Cameroonian went to do colonoscopy and died in the process. How risky is this?
I mean, Divine, there is nothing in life that goes without a risk. Even if I gave you a glass of wine to drink now, in drinking it, you may get it into your lungs. That's an aspiration. So everything in life carries a risk. So it's the same story with screening procedures for colon cancer. Now, the most common and preferred screening test for colon cancer is a colonoscopy. I'm hopeful that we will talk a little bit about the different screening modalities and explain what they do, and hopefully people can make an informed decision to make a choice.
You can do that right now.
Is the best. So let's take a step back and talk about how we screen for colon cancer. There are two main categories of screening tests for colon cancer. You can divide them into what we call invasive tests and the non-invasive tests.
I will tell you that patients are going to prefer the non-invasive.
and it's their choice. And I want to point out that the decision on which test you choose has to be a discussion between you and your doctor. He explains these different procedures to you, and you make the decision on which one you prefer. I will, at the end of this presentation, tell you the one I prefer. And if you want to know my reasons, listen to me for the next few minutes. The non-invasive tests that are done are typically the stool-based tests. There is also one non-invasive test known as a CT colonography. Now, the non-invasive tests are primarily based on examining your stool. Remember, during this presentation, I said, as the polyp becomes bigger and bigger, they begin to shed, they may bleed. Some of those polyps may also release some genetic material that can be identified in stool. So we have several types of stool tests. We have what we call the fecal occult blood test. We have what we call the FIT test, which is the fecal immunohistochemical test. And we have the Cologuard test, which typically combines the FIT or the FIT test and identification of DNA shed by polyps. These tests are non-invasive because you simply donate a stool sample. You don't, in fact, you're given a test kit that arrives home, you poop inside, ship it back, and it's examined to see if we can identify any of the things that I mentioned that would suggest that, yes, there is something growing in you, we need to go look for it. And depending on which test you choose, it determines how frequently you will need to be doing the test. Now, for the non-invasive test, you can imagine you're donating a stool sample. When you go and poop, you put out a large fecal matter, and you pick a small portion of it and put in the specimen bottle.
Mm-hmm.
How can you are sampling a very small portion? Perhaps the stool that's just around the corner is actually where the abnormality is found. And you did not know, so you could not sample it. And the sample you took is exactly what you sent in. We looked at it and said there was nothing. Whereas if you had taken the sample just a millimeter beside what you did, you may have picked up on what is being identified. So you
Correct.
can see why these tests, even though some test is better than nothing, has a higher probability that we might not miss something that is in you and tell you there is nothing, whereas there is something in you. And remember, small polyps are unlikely to shed anything that we can identify or bleed. So most often than not, it is also advanced polyps, meaning polyps that are bigger in size, the more aggressive types of polyps that shed the kind of stuff that we look for in stool. So those are the stool-based tests. The other non-invasive test is the CT colonography. It's a kind of CT scan where they're actually going to give you a lot of dye to drink that distends your colon. And then you have a CT scan that tries to see if there are any bumps. Remember, we said a polyp is a small growth or a bump that grows in your colon, that if not removed can grow into a cancer. So if it is big enough, the CT scan may say, hey, I see something, a bump here. That is probably a polyp. Ultimately, if the non-invasive tests are positive, you have to undergo an invasive test to go and get it out. They can only tell you there may be something. We go in. And a lot of times, there are a lot of things that can interfere with the sensitivity of these tests. You may take a medication like Advil, ibuprofen. That can cause you to bleed. The fecal occult blood test may identify the blood. Was that from a polyp? No. So you will undergo a colonoscopy for a false positive test. Now, we now move over to talk about the invasive tests. The invasive test, it's primarily two main ones. It's known as a flexible sigmoidoscopy, which is a shorter form of scope. Sorry, Divine, let me drink some juice.
Yeah, go ahead.
Which is a shorter form of a colonoscopy. We typically will examine only the left side of the colon because that scope can only go in about 40 to 60 centimeters. We will not go past what we call the splenic flexure. So with that test, we can identify things on the left side, but what of the right side? So that's why a colonoscopy examines the entire colon. What is the main advantage of the invasive as compared to the non-invasive? Well, I can see, but not only see, but I can do something. And what is the something I can do? I can remove the polyp, just like I did today. If this patient had had a stool test, possibly they may even say, we don't see anything because the polyp may not be bleeding. So they wouldn't have come in. And even if the test was positive, they will still come and do a colonoscopy to get it done.
Doctor, let me ask you this. Are there certain things that have to be done if you have to go for the invasive screening? Are there certain things that you doctors have to do before to just make sure that what probably happened to that Cameroonian doesn't happen to the patient you are about to work on?
Well, so typically, before your procedure, we assess the risk of the patient in terms of the kind of sedation they will get. On the day of your procedure, before, of course, for the invasive test, you need to do a kind of bowel prep. You need to cleanse so that we can see. If we scope a dirty colon, unfortunately, if there are polyps, they may be hidden under the stool. And that test will not benefit you because I will not see that polyp and therefore not remove it. In that scenario, I may tell you, I did not see anything. You go home and you are happy, you go around drinking your wine, that you're doing well. And tomorrow you come in and you have a cancer. So it is very important that folks do the bowel prep. I know people complain. It is too harsh. It is too... Just think about having a cancer and having to go for surgery or do chemotherapy. You see people who do chemotherapy, sometimes they've lost all their hair, they develop terrible infections, they've lost weight, they can't come out of the house. If that's what you prefer over doing a bowel prep, I wish you good luck. But I will take the bowel prep every day, every second, every time over developing a colon cancer. So please, when you have to go in, do the bowel prep. Drink to the last bit of the liquid that you are given so that you give yourself the best chance that you have cleaned out completely and we can see. It doesn't mean we don't miss polyps. We can miss especially small polyps. But remember, a polyp takes 10 years to grow into a cancer. Even if I miss a small polyp and you have to come back in 5 years, the chance that that polyp would have grown into a cancer is very small. So I'm not saying a colonoscopy guarantees you 100% freedom from colon cancer, but it certainly offers you the best chance. It examines not only the left side, like the flexible sigmoidoscopy, but it examines the entire colon and will remove. And when we see polyps, 99% of the times we can remove them during that procedure. Sometimes if the polyp is already too big and we cannot remove it at that time, we may rearrange to do it later on, or you may be referred to a surgeon to have that polyp removed. So before your procedure, we usually, remember, screening is done on healthy individuals, people who don't have symptoms. So most often than not, these are people who are healthy and do not have a lot of other comorbidities or diseases or illnesses that are going on. They can usually go through the procedure and come out without any problem. Now, if you have a lot of other medical conditions going on, we may be forced to get a higher degree of anesthesia where you may need to be intubated and be knocked out completely, or get what we call a more advanced form of sedation if we think that you cannot support moderate sedation. For example, if a patient has been taking a lot of pain medicines or the medicines that we use to sedate you, we will not give you those kind of medicine because you will be resistant, or you will develop tolerance to them. In that case, we may resort to anesthesia, knocking you out with propofol, and if you are too sick, some patients may need to be intubated. That said, just like I said at the beginning, there are risks for every procedure, and the most common risk for a colonoscopy is the procedure itself, which is bleeding. Bleeding is the most common complication following a colonoscopy, and that typically happens when we take out big polyps. For example, when I took out the polyp today, I told the patient, I will not be surprised that you go home and you show up to the ER because you're bleeding. It is one of the most common complications. And remember, I'm trying to cut a polyp from the wall of the colon. If I cutting that polyp, I may cut too deep, and that may cause a hole in your colon. That's a perforation. The chances of bleeding following a colonoscopy, especially if you have polypectomy, is about 8 out of 10,000 colonoscopies. You can say 4 out of every 5,000, 2 out of every 2,500. The risk of a perforation is far less than that. But these are things that can happen. So bleeding, perforation, the two main things. Sometimes in going in, a patient, especially patients that have had multiple surgery to their abdomen, they've developed scar tissue that is holding their colon in place, and I cannot navigate through easily. In trying to push in that difficult patient, I may poke a hole in the colon. So that does not come from a colon, from removing a polyp. We can poke a hole. That would be a perforation. Sometimes the nearby organs to the colon, you may induce enough trauma to these organs. Like, for example, you can lacerate the spleen. You can lacerate the liver. These are very rare complications, but they can occur in patients that undergo colonoscopy. Now, the other thing is we give medications. Remember, every medicine can have a side effect. I can give you medications now and you stop breathing. We have to respond. Some patients, they receive medications, their heart rate goes down. Some patients during the procedure, they have a bit of pain and they are bearing down, they are holding their breath, their heart rate goes down, and they develop what we call a syncope or vagal reaction. that we have to address. So those are things that can happen related to the procedure, related to the medications. And sometimes, if you did not screen your patient well in terms of what diseases they have that puts them at higher risk, and you give them the wrong level of sedation, they may also develop complications due to that. So, but despite all these things, the conclusion is that the advantages of undergoing colonoscopy far, far outweigh the risk and any disadvantage. So do not listen to this and think, oh my God, am I going to have one of these? No, the advantages of undergoing a colonoscopy far outweigh the risk and the disadvantages. Otherwise, it will not be recommended.
Keep watching Chatnite Africa.
A question just came in by text. Dr. Dieter, you talked about chemo. The person is saying that they have seen people who died in spite of the chemo, and relatives are saying if they had to do it all over again, chemo isn't what they will do. Why are these people wrong?
No, they are not wrong. Now, when you are caught between a rock and a hard place, sometimes you don't have a choice. When you are that individual who is sitting with your doctor, and the doctor says, look, you have advanced disease. If you wait and you are coming late and your disease has spread, I mentioned here tonight that even if I take out the tumor, unfortunately, if the disease has gone to another organ, I may not be able to take out that organ. The only way to treat that organ may be the use of chemotherapy. In that situation, your doctor will sit you down and discuss with you and tell you that if you do not get chemo, this lesion that has gone here is going to progress and you will die from it. There is a chance that if you receive chemo, we may be able to get rid of this. No chemo and different chemotherapeutic regimens have different levels of efficacy. No one chemo can guarantee you 100% cure. And that's why they typically try to use a combination of several different medications. And some people show response, and some people do not show response. Remember, tumors, the biology of tumors is very different from one individual to the other. Even in the same person that has two cancers in the colon, the two cancers may have a completely different biology, meaning the way they will respond to chemotherapy is not the same. One may be completely responsive and you get into remission, and the other may not be responsive. And chemo by itself is typically not very specific. They try to get as specific as they can. But unfortunately, a lot of the things that the cancer cells show are also present on normal cells. So when they give you chemo to go target the cancer cell, even though the cancer will receive most of the chemo will also attack the other cells that have the same kind of tissue, which is found in the cancer cell, but even though that cell was normal. So you are likely to develop a complication due to the chemo attacking a cell that was healthy in the process of trying to attack the sick cell. So the short answer to that question is, some tumors can respond because the biology of tumors are different. Some tumors will not respond and the disease will flourish and become much more extensive. And unfortunately, in that scenario, there may be very little we can do. And the best sometimes is to offer them comfort care, or what you described earlier as palliative care.
We love Chatnite Africa.
Dr. Dieter, before we go, what's the life expectancy with colon cancer?
Divinely, as you can imagine, if colon cancer is diagnosed at different stages, depending on what stage your disease is, that also determines your prognosis. So stage of diagnosis determines how long you may be able to live. Take, for example, the cancer is still only in the colon, and we chop out that part of the colon, you are cured. If the cancer has spread to a neighboring organ, and we can chop out your colon and clean that neighboring organ and get it rid of cancer, you may be cured. But remember, I'm now saying you may. So depending on the stage where you are diagnosed, the chances of survival also differ. Early disease, you may be cured and you live and have a normal life expectancy like anyone that did not have colon cancer. But if you have advanced disease, depending on how advanced and what organs are involved, your prognosis will also differ. It may be months, it may be years, but it can also be days.
Dr. Dieter, has anybody ever survived stage 4 colon cancer?
Well, in my experience, some people have. For example, there are people who have colon cancer with a single metastasis to the liver and no disease anywhere else. Some of those patients, they can chop off that colon and go to that liver and resect that single lesion. And some of them may get chemo, some may not, but most often they get what we call adjuvant chemotherapy. If that was how limited your disease was, and you were lucky to only have that one lesion in the liver, you may actually be cured. But that would have been classified as stage 4 disease. So the answer is yes, it is possible, but it is exceptional to see.
My last question is a terrible question. I hate to ask it, but I must. Dr. Dieter, when all else fails, what next?
Palliative care, unfortunately, comfort care. If you didn't get your screening, developed the cancer, and came in at a stage where it was too advanced, for example, disease in the liver, disease in the lungs, disease in your peritoneum, disease everywhere, the best response, answer, or treatment is often nothing. Because irrespective of what is done, you will not make it. And given that chemo has a lot of side effects, we may actually be offering you a bad quality of life for the rest of the time that you have. Sometimes it's better to not do anything and allow them to have some quality of life, talk to their friends, talk to their families, tell their family where they've hidden money so that they can get it when, unfortunately, they take their last breath.
I know I said the last question. Why is it that when you see people at the last stages of their lives, people who have cancer, they're often so emaciated? Is it that the cancer eats up the flesh, or what happens, and they are in so much pain?
Yeah, and that's true. So as cancer becomes very advanced, there are certain the biology of the cancer changes, and it affects the entire body mechanism and physiology. There are syndromes that we call paraneoplastic syndromes, where the cancer begins to produce certain substances that may affect nerves and cause a lot of pain. They might affect your appetite and cause you not to be able to eat, because the tumor is so much in your body and the tumor needs so much energy. First, it decreases your appetite, and then number two, it breaks your body down because it needs the energy to survive. And that's how it overwhelms your body, and it produces certain substances that lead to that breakdown known as paraneoplastic syndrome. And that's why those patients in the end stages of their disease, they're so exhausted, they are emaciated, their appetite is finished, the tumor produces these substances that affect the nerves and causes a lot of pain, to an extent where sometimes they can't speak, they can't even move. And I remember when HIV came, and when we didn't have a lot of treatment and people developed AIDS, it's exactly how some of these patients look at the end of life. It is actually very pathetic and sad. The good news is that for colon cancer, you don't have to wait.
And you don't have to go through this pain. Ladies and gentlemen, the inconvenience of colonoscopy is nothing compared to the unfathomable pain that you go through when you are told that you have developed cancer. Dr. Dieter, in 1 minute, what's your last word?
Again, Divine, I want to thank you for inviting me here today. I am hopeful that we were able to cover the most important aspects of colon cancer in this presentation. Before we go, I would like to make a brief summary of this presentation. I want the audience to remember that colon cancer is a very important public health problem. So many people are affected annually. We talked here tonight that the one strongest risk factor for every individual for colon cancer is age. And the age at which every person who is not at increased risk to get colon cancer screening is the age 45. For the Black folks listening tonight, we Black folks are at higher risk of developing more advanced disease than their white Caucasians. So if there is any race that need to pay attention as to when they must start colon cancer screening, it is the Black African American individuals.
And Africans.
Yes. The risk, we talked about average risk, but we also cited some factors that may indicate that you are at a higher risk. If you come from a family with individuals with colon cancer, talk to your doctor to determine if you need to start earlier. If you have chronic inflammatory conditions that involve the colon, talk to your doctor to see if you are at increased risk. We did also talk about some modifiable risk factors that you as an individual can do to decrease your risk of colon cancer. If you smoke, quit. If you drink excessive amounts of alcohol, quit. If you eat too much red meat or processed meat, decrease it. If your diet is low in fiber, please increase your fiber intake. We discourage sedentary lifestyle. If you are big, or I hate to say big, if you are obese or you fall in a weight bracket that is not appropriate for you, you need to do everything to lose weight. And we also said high-fat diets also put you at an increased risk. These are factors that you, Divine, me, Dr. Dieter, can do something about. We cannot do anything about age. We can't do anything about genetic factors, but we can do something about this. The good news, as I mentioned, is that polyps take 10 years to develop. And when a polyp is developing, you have no symptoms. That is the time we can do something to take out the polyp. So please go get screened. Do not wait for symptoms to happen. And if you wait and you develop any of the symptoms I listed here tonight, please do not delay, because it is better to catch the disease or the cancer in its early stage, where we can do something, than to come in late when the disease has advanced. There are several modalities to screen. We talked about the non-invasive and the invasive. Talk to your doctor to make a decision on which option is better for you. Screening with any of those methods is more important than having no screening. But as for me, for my loved ones, I recommend that you get a colonoscopy. And with that, Divine, I thank you very much for inviting me. If people have questions that they would like to ask, they can always go to the website, send those questions. We will address them. Thank you.
Wow. Beautiful. Thank you so much, Dr. Dieter. I have to say that each time we come knocking, you answer in the affirmative. You are one of the doctors who just cannot abandon your audiences at Chatnite Africa. We were here when you had to flip a phone, do this and that. See what we have now. See what we have now. Our desire to give you the best knows no limits, and we will continue. I want to thank all the friends who've been supporting. This thing is expensive to produce what you are seeing now. It's not cheap. I want to thank everybody who has been supporting. I want to thank my director of transmission, Mr. Mumbalingwa in Chicago. I also want to thank my lieutenant, the chief of technology at Chatnite Africa, who is awake at this time of the night in Nigeria to make sure that we are on all the social media platforms, hitting the entire planet. Thank you, Ze Roger Full. Dr. Dieter, I appreciate you. Give my love to your family. I don't know how your parents did it, your mom did it, and dad, 4 of you from the same womb as specialized medical doctors. I don't know. Each time that meant they were producing medical doctors. Thank you, sir. Thank you.
Thank you, and happy Easter to you and the entire Chatnite audience.
Thank you. Ladies and gentlemen, before I go, I have something very special for you. Watch this. It's from the northwest region of Cameroon. Here we go.
Exclusive from Demos Records.
Hiya, hiya, hiya.
And that
I'm coming back. I'm coming back. I'm coming. Coming to get down. I'm coming. I'm coming. Coming to dance. To dance. We're gonna dance. We're gonna dance. We're gonna get down. We're gonna get down. We're gonna party. Party hardy. We're gonna boogie. Boogie woogie. And when we jam, it's out of sight. This song right here, it's dynamite. I'm ready.